This is the mic. Okay. All right. I'm going to offer a positive view in contrast to this sort of dour last 20 minutes you've had to experience. I hope you can regain a sense of hope in the future. My premises are fairly simple. We should help people, and we should pay to help people with health coverage. If you don't want to do it, tell us who should not be covered. Or describe a realistic alternative. And please watch out for vague invocations of budgetary threats that are invoked uniquely when it comes to care of the poor, but not for any other major federal expenditure. So what was the problem we were dealing with before that led to this law? Being uninsured is bad. This is just comparative survey data of different kinds of services that people had trouble getting, comparing the insured in the United States, who are the fourth column over, and the uninsured in the United States, the fifth column over, to people in other countries. And clearly getting a number of services, filling prescriptions, et cetera, is a lot harder if you're uninsured. Just a few other things to mention. In one study, I think this is, I don't remember which sample it's from, but people who were uninsured and hospitalized experienced years of financial harm with unpaid medical bills and a higher likelihood of bankruptcy. In quasi-experimental data, which we can debate, there's lower mortality if one is insured. And think about the harms to children and families when this kind of financial devastation hits. What happens to the kids in a family which cannot afford to pay for whatever it is? It could be after-school sports, it could be transportation, it could be clothing. This is a devastating event when you're uninsured and have a serious illness. In terms of the Pre-Affordable Care Act market, my response to Tom is good riddance. Key parts of that market were underwriting and evaluating the risk of each consumer and rejecting consumers. The goal was to not sell to people that would be a bad risk. Denial, as according to the Government Accounting Agency, looking across many, many insurers across most states, this is just an average rate. The reported rate at which insurers denied offering anything to a seeking customer was between 19 and 22% average. It ranged as high as 70% among some insurers. So this is not a market that wanted to sell to all. And of course, that's the market Tom wants to take us back to. In 2008, among insurance shoppers, 57% reported it was difficult or impossible to find an affordable plan. And 70% reported so if they had a prior health problem. This doesn't sound to me like a wonderful market. Pregnancy was not typically covered because, as you all know, it's the woman's fault. She needs to deal with it. And you know, maybe not super common, but the rescission of policies was a difficult thing that came up from time to time, and certainly made for the Michael Moore movie, which I encourage you to watch. But we agree that it wasn't absolutely routine. The Affordable Care Act is somewhat straightforward. It's I don't like white on yellow. I'm disappointed now with my color choice. But you got three basic premises, three-legged stool. The top one is that the insurer must sell to everyone, not based on their health risk. This addresses the issue of pre-existing conditions. The lower left-hand one says everybody has to buy in. There has to be a mandate. That avoids the death spiral. The other side is that there have to be subsidies for people who can't pay. That also is meant to avoid the death spiral. Additionally, people who are better off are essentially helping pay for people who are less well off, either due to differences in illness, or if you're younger, you're helping pay for older people. The government regulates what's sold and covered. And in this approach, no one decided to pull the plug on employer-sponsored insurance. So that was a political arrangement, essentially. No one felt that was possible to say, oh, let's just get rid of employer-sponsored insurance. Can't refuse to cover pregnancy, and there has to be care for mental illness and addiction and parity with other problems, which has been a long-term issue. No more prominent than now. Coverage gain estimates. This is one estimate. I realize Tom gave you a lower one. I looked at a conservative website called American Action Forum. They provided estimates of the coverage gains from a low of roughly 11 million to a high of 30 million, and their middle estimate was 20 million from a conservative site. Medicaid grew by 14.9 million, but maybe some of those people were people who jumped in but weren't necessarily made eligible by virtue of the law itself. And the total individual insurance market grew. Employer-provided insurance did not shrink, contrary to what you heard. It shrank a little bit last year, though, so I don't have a slide for it, but yes. In smaller firms, the percentage that are offering insurance definitely dropped from last year to this year. By 5 to 8% of those firms, fewer firms are offering it. How about the exchanges? Are they doing badly? So this is the percentage of persons under 65 with private health insurance obtained through the health insurance marketplace from January 2014 to December 2016, broken out by age. And what you see is a big bump up at the end of 2015, and then a stability in 2016. I'd like to see what happens in the first quarter of 2017. I don't know if there's going to be a bump up there or not. But the number should have grown more, and that signifies some of the distress due to the increased premiums probably. But it also doesn't look like a number that's falling through the floor. Private insurers, are they in deep trouble? Last year we heard that our Blue Cross Blue Shield of many states sought big premium increases because they essentially had miscalculated the amount of risk they were going to face. In the last year, first quarter of 2017 at least, the spread between the premium paid and the claims they had to pay out reached an all-time high on average. That may not be the case locally, but we'll find out. But I mean, this doesn't look like a situation of financial distress when you're making more off of each premium than you have to pay out. Every year, Dr. Huddle gives us an overview of a range of disasters that are either about to happen or are happening, beginning to happen, and they're all impossible to disprove because when you say it hasn't happened yet, he says, well, it still could. This is just kind of a range of them. There'll be a loss of employer insurance for 35 million Americans. That was the projection about 7 years ago when we held this debate. It's not happened. No one will pay penalties because the mandate's toothless. There's some truth to that, but a lot of people just pay what's ever on their tax form, it turns out, and that's how we do it. Employers will increase part-time work. People will choose to work less. Costs will bust the federal budget. The ACA won't resolve many problems. There'll be a death spiral. Let's just talk a little bit about some of these. For this year, the current estimate of the likely premium increases has to be broken into two categories because of our current politics. One is based on 40 states where premium increases have been requested. If there's no Trump tax, which is what Charles Gaba calls it, that means if the federal government does provide some of the funding to help insurers cover the cost of reducing out-of-pocket expenses to their clients, their poorer customers, then they are seeking 13.8% on average across the country. If Congress and the President go full on and say, look, we're going to really, really, really not enforce the mandate, and we're not going to provide any kinds of these payments that were sort of built into the Affordable Care Act but are legally disputed, well, then we're going to have to charge a lot more. So there would be a large premium increase. And that's just averaging across the 40 states that have requested these premium rates. It could change once the states approve or don't approve those requested rates. There are indeed problems with getting coverage in some counties. You can only get a subsidy if you're on an exchange. There are 1,300 counties that have only one insurer, which means you don't have much choice. And I think there's about 40 where there's no insurer. It turns out that a lot of this is based on whether your state was interested in the Affordable Care Act. So when you break it out by where are the people living in the counties with only one insurer, it's mostly people who are in a Republican state that oppose the law. The one group where there is a Democratic governor now is North Carolina, but that's a very recent change. So essentially, about 1.8% of people who are in those democratically governed states, setting aside North Carolina with a recent change, are having that problem. So a lot of this has to do with what alacrity does your state government pick up on the Affordable Care Act. How about cost sharing? So the key thing, I mentioned this earlier, what Charles Gaba calls the Trump tax, but the Affordable Care Act is supposed to reduce out-of-pocket costs for people making less than 200% of poverty. There's supposed to be $7 billion that come in. There's a real legal reason why that may not, because formally Congress has to appropriate that money. There's kind of a standoff right now while the Trump administration tries to decide whether to uphold the Obama administration's challenge to the ruling against this. That's just how confusing this is. But essentially, it's a sort of Damocles. The president could decide tonight, I don't wish to pursue allowing the $7 billion thing to happen, and it will stop. At that point, the insurers have a few choices. They could leave the market. They can raise the premiums. This is by how much across states. And then in doing so, of course, people who are under, I don't know what it is, 300 or 350% of poverty will get more and more subsidies to cover up for the problem of the premium going up. And then this would make the market less stable. So this is something that could happen. There is this criticism that people will decide not to work. They'll leave the market for labor because their income is going to rise as a result of getting a benefit from the government. The Congressional Budget Office definitely thought that would happen, but it's not so simple. This is just out last month, Stanford economic team. First of all, I'll just mention, the Oregon health insurance experiment looked carefully at whether providing Medicaid caused people to stop working. Answer, no. So far, as of July 2017, answer, no. The question is, do you quit working because you've been working for your health insurance now that you can somehow get Medicaid? And that's tricky. It's a very hard thing to calculate. Some of the estimates that went into the CBO's work were based on the idea that when people were pulled off of Medicaid in prior years, they jumped into the labor market. So the thought was, okay, if they're offered Medicaid, they're probably going to jump out. But maybe people don't behave exactly like that rule would expect. Some people may work more to get exchange subsidies. The assessment to defend the idea that the labor market is about to suffer significant harm, despite all this evidence, is you never know, it might still happen, from Antos and Capretta. Note the year. They said that in 2016 because the same group published a paper a year earlier saying, hey, there's no harm to the labor market. And they said, well, you never know, it might still happen. A year later, another paper, hey, there's no harm to the labor market. The last line of opposition to the Affordable Care Act is we did it wrong. Why not be a free market country like Singapore, which came up in one of the previous lectures? So let's talk about Singapore, the great example of free market healthcare. They have subsidies for much of the healthcare system, particularly for long-term care and for the hospitals. People are required mandatory savings of 7 to 9.5%, no choice about it. The government demands that you set aside money in these accounts called MediSave. If you don't like mandates, you better not like this. Then there's MediShield Life and Integrated Life Plans. This is kind of catastrophic health plans that people are auto-enrolled into, although they can opt out. And then there's a safety net fund, which essentially is an endowment, and they can only spend the interest each year to help people who are in trouble. And hospital boards decide who needs it. So the great thing about Singapore is the prices are pretty low. An emergency department visit's $89. If you're willing to stay in a 5-bed hospital room, you're going to pay $512 a night. Most hospitals are owned by the government. 51% of the hospital costs are simply paid for by the government, not through any of those insurance plans I discussed, except for the subsidies part at the top. The government decides what drugs can be bought with the MediSave accounts, and it decides at what price. So that's free market capitalism for you. The average U.S. health plan deductible is considerably higher than the average Singaporean's cost exposure. So we actually have more skin in the game than any Singaporean does in their wonderful free market capitalism system. And it's, kind of, people argue whether it's a democracy or sort of a dictatorship. 6 million people, not crystal clear it could be transplanted here. Now, we still have a major cost problem in American healthcare. Tom is certainly correct about that. We do. These are mostly, I've mixed mostly 2024 projections for our healthcare system. We're going to spend $5.5 trillion as a country on healthcare. The federal government will spend directly $2.3 trillion in 2024. I got a different estimate, but it'll also give up $1 trillion because it doesn't tax employer-sponsored health insurance. That's a lot of cost. Now, we can debate, does this $160 billion that got people who are poor onto healthcare, was that a good idea given this incredible threat over here? But you can eliminate it, and we're still going to have the same problem. I mean, 1.16 trillion just won't speak to the rest of that equation. What matters most? This is getting to the values part of the discussion. Net cost of the Affordable Care Act, if you assume it doesn't pay for itself, $156 billion in 2024. We talk about this as a big old problem. I mean, I sat with Senator Shelby. He talked about entitlements, and we're going to bust the budget. It's going to ruin us. What don't we talk about? We don't talk about the $96 billion for the mortgage interest tax deduction in 2019, which enables well-off people in Homewood and Mountain Brook to get a nice big tax deduction when they buy their home. It's American as apple pie. We don't really talk about the employer insurance tax subsidy. This is, I think, projected into the future. Current year, $412 billion. And we certainly don't talk about the cost of the extension of the Bush tax cuts in 2012, which projected in 2021 would cost $500 billion. No one is worried about this. This is all not budget busting. This is all just normal stuff that we don't discuss. It's off the radar. What's on the radar are these poor people. Value judgments really lie at the core of our debates. You should always ask this: who should not get care in your view? If the answer is everyone should get care, then you need to ask, well, how are you going to do it? If your interlocutor moves into a selective invocation of the deficit, financial disaster, labor incentives, and moral hazard, your question has not been answered. This is a great example of where we are. This is a letter from HHS on Medicaid and how the current Medicaid leadership wants to make states freer to add premiums, charge people, kick people off the rolls, etc. But read the logic. Providing much higher federal reimbursement, the ACA provided states with an incentive to deprioritize the most vulnerable. This puts upward pressure on both state and federal spending. Don't want to deprioritize the most vulnerable. And this gets you to the ultimate unbeatable arguments against helping people who are poor. You can never win these arguments. You need to listen for them very carefully. You propose a benefit for the poor. The first question that will come up in any governmental discussion is it means tested? Does it mean that the poor will get it and people will not get it as they're better off? You say, well, yes, it's progressive and it's means tested. The next line, which usually comes from economists at the University of Chicago, I'm an alma mater, is that will discourage work. It will incentivize laziness and create a dependent class because the option of getting a job will always look less attractive by virtue of your means-tested benefit. They're going to lose it. So we better not do it. Okay, so try the alternative. You say, no, it's not means-tested. Everybody gets it. We're just going to make sure that everybody gets this no matter what. Then usually another economist, usually from the University of Chicago, alma mater, says, wow, that's costly and violates the idea of helping the neediest. Why would you ever do that? Oh, my goodness, it's not even just. You've just deprioritized the most vulnerable. Answer, we can never do that. Now, we use a very different logic when we debate benefits for the well-off and middle-income people. The first question is, does the benefit exist? Answer, yes. Oh, it's America. You earned it. We won't be discussing it further. Examples, tax-deductible employer insurance, the mortgage interest tax deduction. It's off the table. We will not discuss it for the next decade, I guarantee you. Does the benefit exist? No. Well, let's go ahead and get it for you. Example, Medicare Part D. Entirely different logic is applied whenever the benefits are for a different group. So, final points, lacking coverage is devastating. The ACA did not reform the vested interest amalgam of U.S. healthcare, and Tom is 100% right on that. Arguing that it must have or should have done so is a kind of idealism, which I respect, and I have learned over time. Tom is more idealistic than I am. Now, focusing on ACA costs while ignoring more costly middle-class and upper-class set-asides is not exactly idealism. The $5 trillion problem of national health expenditure exists with or without the Affordable Care Act. And that's the end of what I have to say in its defense.
Thank you, Dr. Kertesz, for that trademark wonderful blend of truth and obfuscation. Usually we do a little bit of panel before the break, but because the break is only 5 minutes away, let's go ahead and do the break now. Come back in 2 minutes. We'll convene the panel and have some fun discussion.